Welcome to Clinical Capsules, your go-to podcast and trusted source for quick, evidence-based insights from TRC Healthcare. For 4 decades, we've been keeping healthcare professionals at the forefront of drug information and medical knowledge. And now we're bringing these vital clinical updates right to your ears every second and fourth Tuesday, delivering practical, actionable takeaways in bite-sized episodes. Today, Associate Editor and Clinical Pharmacist Sara Klockars examines tailoring contraceptive use in certain populations in an excerpt from our popular Pharmacy Essential Updates webinar series. Let's dive in.
As our article says, we're getting questions about tailoring contraceptives for special populations due to CDC's updated U.S. medical eligibility criteria. Plus, pharmacists in over 30 states can now provide contraceptives. And this has been evolving in recent years. But regardless of whether your state allows this, we often get lots of questions about hormonal contraceptives. So, this is a great opportunity to refresh our memories and help with safe contraceptive use. So, let's kick things off with a case. Nikki is a 31-year-old and she comes to the pharmacy asking about the pill. Until now, she's been using condoms as her main form of birth control, but now she's been in a relationship for several months, so she thought the pill might be a better choice. So, what questions should you ask her? What's your next step? For the pharmacist, what information do you want to know to help recommend a safe contraceptive? So, to get ourselves on the same page about the various contraceptives available, when it comes to safe use, we often put contraceptives into 3 buckets. We have non-hormonal options, and these options include the copper-containing intrauterine device, or IUD, barrier methods such as condoms or diaphragms, and then behavioral methods such as fertility awareness-based methods. Then we have 2 main groups of our hormonal options. We have combined hormonal contraceptives, which contain both an estrogen and a progestin. And these include combo oral contraceptives, hormonal patches like Xulane, and then rings like NuvaRing. There are progestin-only contraceptives, which do not contain an estrogen. And these include oral progestin-only pills like norethindrone, the injectable depo-medroxyprogesterone or Depo-Provera, and then the implant etonorgestrel or Nexplanon, and then intrauterine devices or IUDs with levonorgestrel, such as Mirena. So when sorting through all of the options, we can tailor our recommendations based on patient preferences, and then their medical history and comorbidities, and then just narrow in from there. So let's briefly review that first bucket about considering patient preferences. As we know, deciding on which contraceptive option relies on shared decision-making with the patient. And there are many factors we can consider and discuss with patients, things like efficacy, or maybe they have a preferred dosage form. And we have to think about adherence, along with other considerations like cost or side effects, and then ultimately have that discussion with the patient, and it's the patient's decision. So moving on to that second bucket, we need to think about some background information in the patient's medical history. The patient's medical history may guide which contraceptive to use. For example, using oral contraceptives to treat acne or to help control heavy bleeding. But then their medical history can also determine if certain products need to be ruled out due to possible risks or safety concerns. And this is where we're going to spend most of our time today. And that brings us to a recent update of the U.S. medical eligibility criteria, or what you may hear as called the MEC for contraceptive use. It's the first full update since 2016. The MEC provides recommendations for the use of specific contraceptive methods by persons who have certain characteristics or medical conditions, and it's just available to help guide safe use and help us weigh those risks and benefits of the different contraceptive options out there. Some of you may be familiar with the MEC summary table, but let's take a minute to review how this table is set up. And to orient you, the conditions are on the left, and the contraceptive option abbreviations are across the top. And then we have numbers and colors in the table with a key at the bottom. So for instance, the number 1 or bright green means no restriction, and the method can be used. A 2 means advantages generally outweigh risks. 3 means risks usually outweigh advantages. And then number 4 or dark pink means unacceptable health risk, and the method should not be used. So if a patient has current breast cancer, we see mostly 4s. So we should avoid most contraceptive options. And the green box with a 1 is the safer option for this patient. And that's the non-hormonal copper-containing IUD. Since breast cancer can be hormone sensitive, we're going to want to avoid all those other hormonal options. So when evaluating a patient for a contraceptive, some of the big questions we want to address involve the patient's health history. We'd want to know the patient's pregnancy status, or if they're breastfeeding, if they've ever had breast cancer or blood clot or a stroke. We also want to know if they smoke cigarettes or if patients get migraines. It's also important to ask about medications or supplements. And then we want to make sure we document any pertinent findings in the patient's profile. If you're one of the pharmacists involved in prescribing contraceptives, you may be familiar with your state's questionnaire. And this example is taken from the Colorado State Board of Pharmacy approved statewide protocol for prescribing contraceptives. And it's a collaborative pharmacy practice statewide protocol authorizing qualified Colorado licensed pharmacists to perform the pertinent physical assessments and prescribe contraceptives under the conditions of the protocol. And part of this protocol includes a self-screening questionnaire, which includes the questions we just reviewed and many others. And it also includes an algorithm to help guide safe use based on those patient-specific conditions and medical history. So this is just one example, but be sure to check out your local legislation for the most accurate and up-to-date information for your state. And then just also keep in mind to follow your pharmacy policies and procedures as well. So after we get the patient's answers, we want to continue to screen patients for contraindications. So, for example, we wouldn't recommend an IUD for a patient with acute pelvic inflammatory disease. Or for patients with history of breast cancer or other hormone-sensitive cancers, we should avoid all those hormonal contraceptives, since those hormones may promote cancer growth. And then just keep in mind that estrogen increases level of clotting factors. Progestins modulate estrogen's effects. And so we want to avoid combined hormonal contraceptives in patients with a history of blood clots, stroke, heart attack. And we also want to lean away from estrogen containing contraceptives as risk factors stack up and those risks for thrombosis increase. So, let's talk about some contraceptive considerations for patients with certain characteristics or medical conditions, and then discuss which contraceptive options are safer for certain populations. For patients on hemodialysis, peritoneal dialysis, or with current nephrotic syndrome, we'd want to suggest a safer option of a copper or levonorgestrel IUD, an implant, or a progestin-only pill without drospirenone, especially in a patient with a history of high potassium. We would not want to use a drospirenone-containing progestin-only pill in a patient with elevated potassium. And we'd want to avoid combo hormonal contraceptives since patients with severe CKD or nephrotic syndrome are at a higher risk of blood clots or thrombosis than the general population. We'd also try to avoid depot-medroxyprogesterone since in some populations this injectable has been associated with increased risk for thrombosis compared to non-users of depot-medroxyprogesterone. For most patients with diabetes, any form of contraception is acceptable. But if patients have microvascular disease, which is nephropathy or kidney disease, retinopathy or neuropathy, or other vascular disease, or if they've had diabetes for over 20 years, we should lean toward the safer options of a copper or levonorgestrel IUD, implant, or progestin-only pill, since these patients may be at risk of cardiovascular events or blood clots, especially if patients have other risk factors present. For patients with hypertension or high blood pressure alone, even if it's controlled on medications, or for patients with multiple risk factors for heart attack or stroke, such as hypertension, older age, smoking, diabetes, we do want to try and avoid combined hormonal contraceptives. The safer options to consider include an IUD, implant, or progestin-only pill. And then risks with contraceptive use in patients with obesity is lacking robust data overall. We do need to consider cardiovascular and clot risk for each individual patient. As these risk factors stack up, there might be an increased risk of thrombosis. And we'd want to lean away from estrogen-containing options if those risks outweigh potential benefits. But with the evidence we have, most forms of contraceptives are acceptable in patients with a BMI of 30 or higher and are a category 1 or 2 on the USMEC. There's no good comparative evidence on the risk of venous thromboembolism or blood clots among contraceptive patch or ring users by weight or BMI. But patches might have a higher blood clot risk and per package labeling are contraindicated in patients with a BMI of 30 or higher. When it comes to those who smoke, any contraceptive is acceptable if there are no other risk factors for thrombosis, if they're under age 35 years. But for patients who are 35 or over, we want to stick with the progestin-only or non-hormonal option. Combo OC users who smoked are at an increased risk of cardiovascular disease, especially heart attack, compared to non-smokers. There's also an increased risk of heart attack with increasing number of cigarettes smoked per day. For patients with active or prior blood clots, usually consider a copper or levonorgestrel IUD, an implant, or progestin-only pill. We do want to watch for exceptions. For example, a patient with an active clot on anticoagulants may also be experiencing heavy menstrual bleeding. So they may be on a combo OC to help limit that heavy bleeding. But generally, if stopping a therapeutic dose of an anticoagulant, we'd usually consider a change to an IUD implant or progestin-only pill to limit any clotting risk. And then patients are at risk of blood clots for several weeks after giving birth. So evaluating other risks of blood clots is necessary, such as smoking, obesity, prior history of blood clots. And if a contraceptive is needed right after giving birth, we'd want to recommend a progestin-only option. So that's where the IUD, implant, injectable, or pill come into place. Or we would recommend a non-hormonal option, such as the copper IUD. And then when it comes to combined hormonal contraceptives, we generally want to wait until after at least 6 weeks postpartum when clotting risk is closer to baseline. But if there are no other risk factors for blood clots, patients can consider combined hormonal contraceptives after 21 days if they're not breastfeeding, or after 30 days postpartum if they are breastfeeding. And we want to just keep in mind that combination contraceptives can also decrease milk supply if breastfeeding. Another consideration is interactions with other meds the patient is taking. So, for example, some meds such as phenytoin or rifampin can reduce the efficacy of any pill, patch, or ring. So it's good to ensure patient profiles include all medications and supplements to help the pharmacist screen for interactions. So now let's say you've gone through this whole process with Nikki. She doesn't really have a preference on what contraceptive she uses. She's heard about the pill from friends. She doesn't smoke but she does have high blood pressure controlled on daily lisinopril hydrochlorothiazide. She doesn't have any other risk factors for blood clots or heart disease. As we discussed earlier, patients with hypertension should generally avoid combined hormonal contraceptives. So she's not a great candidate for the patch, the ring, or combo oral contraceptive. I think we'd want to discuss safer options with her, such as a progestin-only option or an IUD. And then we can use the US MEC to double check and see that the IUD, implant, and progestin-only pill are a category 1. Depo-medroxyprogesterone is a category 2, but combined hormonal contraceptives are category 3. So we can guide her toward the safer options. And this case just reinforces that it's important to individualize your recommendations based on the patient's risk. So now to wrap up this discussion with a few quick practice pearls. We can continue to ensure patient profiles are current with medical conditions, smoking status, pregnancy or breastfeeding status, medications, and then the pharmacist will use this information to help weigh those risks and benefits of options. We also know that there are so many oral contraceptives available, so this is just a good reminder to pick the right product from the computer and from the shelves, and to use safeguards such as double-checking NDCs and scanning barcodes to ensure it's the intended med. So for example, Camrys and Camilla look similar, but selecting the wrong one could cause problems for a patient, since Camrys has estrogen and a progestin, but Camilla is a progestin-only pill. Another example is amethyst and amethia, and these oral contraceptives contain different amounts of hormones. When it comes to comparing contraceptive options, we have our comparison of oral contraceptives and non-oral alternatives chart online. It lists all the different brand and generic names of products available, along with the estrogen dose and the type of progestin and dose to help sort through all of the contraceptive options. Another great resource, our updated chart, Choosing a Contraceptive and Emergency Contraception, and it talks about what to consider when someone's starting out on a contraceptive, reviews considerations for patients with other conditions such as headache or endometriosis, and then it also compares emergency contraceptive options.
We hope you enjoyed and gained practical insights from listening to this presentation. Be sure to follow or subscribe, rate, and review this show on your favorite podcast app. Or find the show on YouTube by searching for TRC Healthcare or clicking the link in the show notes. While you're there, check out our other TRC podcasts like Medication Talk and Rumor vs. Truth. Also in the show notes, we've linked directly to a few of the excellent resources mentioned today, available to subscribers of Pharmacist Letter, Pharmacy Technician's Letter, or Prescriber Insights. On those websites, you'll also find a lot more evidence-based, concise, yet comprehensive resources on this and other medication therapy topics. If you aren't already a subscriber, don't miss out on these resources. Sign up today to stay ahead with trusted insights and tools. We are an industry-leading, non-biased source of information and continuing education. And if you're a student, good news. Students can access a free version of Pharmacist Letter. We've linked to that directly in the show notes as well. Check it out. Find out more about all of our product offerings at trchealthcare.com. You can also reach out to provide feedback or make suggestions by emailing us at contactus@trchealthcare.com. Thanks for listening to Clinical Capsules.